Yes, okay, I think we're ready. Jay's hooking up a new microphone, so I'm going to go ahead and get started. My name is Corey Zavada. Thank you for joining us today. I am Trust Counsel for AHPT. We are bringing you this year's legal and compliance update, and we're going to throw in a little bit of a surprise for you. Dr. Marty McCary has joined us today. I will let him make a full introduction of himself, but Dr. McCary is a surgeon at Johns Hopkins. He is in my world, the COVID spokesperson for Fox News, and we've asked him to join us today to kind of give us updates on COVID, where we are as of today. We know it's a moving target in some areas, but he's going to hit some highlights for us today. We're also going to kind of open it up for a Q&A for those folks that have questions. And then once Marty is done, I will get into some of the regulatory components of issues that we're currently dealing with and what's in the coming year from that standpoint. But I wanted to thank everybody for being on today. And Marty, I'm going to let you go ahead and do your COVID piece. Thank you for being here with me.
Great, Corey. No, it's good to see you again. Good to see everybody, and always happy to do this. And hopefully, we've got some good news here to discuss. Where do we stand with COVID? Oh, by way of background, I'm a head of the Johns Hopkins Islet Transplant Center, and so my experience has been in treating patients and dealing with COVID with issues of infection control in the hospital and then outside the hospital. I'm the editor-in-chief of MedPage Today, which is our second largest trade publication for doctors in the United States. And I also write for the Washington Post and Wall Street Journal and occasionally do some television commentaries, although that's always a stormy sea to dip into. But where we are right now with COVID is that we've got a situation where cases are declining rapidly in most of the country because we've had a staggered Delta wave. Delta hit everybody by surprise. No expert saw Delta or the massive surge in India happening. And yet the massive India surge spawned this new variant that's more contagious, way more than the already very contagious UK strain, which was, if you remember, the highly more contagious strain at the time before Delta. So it's not just twice as contagious, it's multiple-fold more contagious than prior strains because it was twice as contagious as the UK strain. Where do we stand now? Well, the United States got hit with Delta in a way that really ripped through the non-immune adult population quickly. And those are the people in the hospital. Adults with no immunity, no natural immunity, no vaccinated immunity, by and large. The vast majority of people overwhelming hospitals in Montana, Wyoming, Missouri, all over the country where we are seeing hospitals either at the brink or at a very high unsustainable level of capacity during the Delta peak at different points in time. So the first two states that got hit with Delta were Missouri and Arkansas. And so we've watched them deal with Delta and watched the course of Delta as a preview of what we can expect in the other states where Delta came in a staggered fashion chronologically. So right now, cases are way down in Missouri and Arkansas, and we've seen a sort of boom and bust. That is a symmetric incline and then a steep decline. That's what we were hoping for, is the steep decline. And so that's what we're seeing right now. So we're on a good trajectory, and many people believe that this is going to be the final sort of burn through with a population that does not already have immunity, and that it's just happening a lot faster than we anticipated. If we look at where we'll be in 2 months, it's probably going to be a much better place. Now, it is the viral season in the north in the next few months. So we are going to see a small bump in cases, even if it does not correlate with a proportional increase in hospitalizations or deaths. We are going to see a bump in cases probably every year for years, the rest of our lifetime. We're going to see some small bump in COVID cases every viral season, and that's November, December, January in the north, and in the summer, in the south, it's the summertime. So we're going to see very low case numbers now in the next several months in the south, and don't be surprised if you see a small bump. We're talking maybe a tenth of the numbers of cases we've seen during the Delta peak in the coming months. Now, many of us are watching what's happening in the UK, and I know you don't want to hear this right now, but it's important, I think, for all of us to show humility around a virus that has outsmarted every expert in the country. That in the UK, they are seeing a persistent number of high cases with the AY4 variant, aka Delta Plus. It's actually a small family of variants, but it does not appear to be causing a real spike in hospitalizations or severe illness. That's a good sign. It may mean that there's a variant that's spreading around that is going to cause a lot of positive test results, maybe even some mild common cold symptoms, but not correlate with hospitalizations. That would be okay, in my opinion. It's not better to have no viruses on planet Earth, but there's probably 1 million viruses on planet Earth, and 1% have crossed over into human beings. And of those that have, this is one that may be with us seasonally, like 4 other coronaviruses that are with us every season. And they can collectively constitute about 25% of the cases of the common cold. Now, are the vaccines working? Yes, and they're also waning in some situations. So here's where we're seeing the vaccines hold up pretty well. Moderna is holding up better than Pfizer. Why is that? Many of us believe it's because it was given 4 weeks apart as opposed to 3 weeks apart with Pfizer. The longer you space out vaccine doses with any vaccine, the better and stronger and more durable the immune protection. As a matter of fact, there's no vaccine that we give that close together, 3 and 4 weeks. The reason, though, that short interval was chosen is that they wanted to get the trial done quickly. It was not for bad intentions. It was a feeling that this is an emergency. We got to get the study done quickly. Let's give people 2 short interval doses. Well, now the studies have come out showing if you space out the doses by 3 months, your immune protection is stronger, it's better. And so that's what I've been recommending for anybody who has only gotten 1 dose. Wait at least 3 months for the second dose. 3 months, I would say, for the Moderna and Pfizer. With J&J, they just did a formal study looking at getting a second vaccine after the initial J&J vaccine, getting a second one at 2 months versus 6 months. And guess what? 6 months was a lot stronger protection. So the reason we're seeing vaccines wane is that we may have essentially, by giving people 2 doses so close together, given them really 1 functional primer dose. And it's acting as 1 primer. So it may be that you need that second dose to hit the magic sort of level of activating your B and T cells that give you durable immunity. We don't know. We don't really have good data on that. But what we are seeing is that older people are at risk of severe illness at about a 10-fold higher rate than if they got a booster. So we are recommending for people over 65 to get the booster. With Pfizer in particular, Moderna, the cases there, it's not quite as compelling yet. And with J&J, it's not that a vaccine is designed to be 1 dose. You can give any vaccine multiple times. And so you're probably just getting the effect of 1 dose, which was equivalent to getting Pfizer or Moderna so close together. It functioned as 1 dose. So everyday question, should I get a booster? And I tell people they've got to assess their own individual risk and their own risk tolerance. Why do we assume every American has the same risk tolerance? Not everyone is going to have the same risk tolerance as the director of the CDC, who may have no risk tolerance. So I think it's reasonable for people who are low risk and may have a higher risk tolerance to forego the booster for now. We'll see what that immunity looks like in data that's going to be forthcoming. But it may be that what you have is pretty durable, and if your risk tolerance is a little higher, maybe you're good for life. There are some complications from the vaccine, although they are very mild and the serious ones are extremely rare. I think it's important for all of us to be honest with that rather than try to sweep it under the rug. And that fuels the hesitancy when we downplay the complications. There are complications, but they're exceptionally rare in terms of serious complications. That's also an important conversation with children. Now, you may have heard from the Joe Rogan, Sanjay Gupta podcast interview. Joe Rogan made this very strong point that Sanjay Gupta had a tough time speaking to. And that was, he asked him, isn't it true that Dr. Gupta is not worried about COVID for himself. He's not worried. He said that clearly because he's been vaccinated and he's low risk. And Joe Rogan said, well, you are still at more risk than a child who's unvaccinated. So if you're not worried about yourself being vaccinated and low risk, and you're at greater risk of COVID severe illness than a young child with no vaccine, do you understand how people are not worried about their kids? And he had a very tough time answering that question. And that's what people said, this raises a good point. It's almost as if kids have 1 or 2 doses built into their system relative to someone over 65. Now, there have been almost 700 kids who have died of COVID over 2 years, and that's real. We do believe that they are kids with comorbidities, nearly all of them. And so if a kid has a comorbid condition, I would say the answer as to whether or not you should get your kid vaccinated is a definite yes. If a kid has had COVID in the past and has natural immunity, or if anyone has had COVID in the past and has natural immunity, do they need a vaccine? Well, the data so far are pretty compelling that natural immunity is effective in the time in which it's been studied. Now, we don't have 10-year follow-up data on natural immunity from COVID because it's only been around for 19, 20 months. So we do have good data now at 6 to 10 months, and it shows that natural immunity is 27 times more protective than vaccinated immunity in preventing severe illness. Why don't you hear about this? Well, it's in part because doctors are concerned, and this is an open concern, and I share a little bit of this concern, is that if people see how much more effective natural immunity is, they may choose to not get the vaccine and choose to get COVID instead. We don't want people doing that. That's why you're not hearing that much about natural immunity, in my opinion. Actually, many experts have told me privately that's exactly why they're not talking about it. But for those who have already had it, de facto, if I can use Corey's legal term, if you approve, that is, look, they're not choosing to get natural immunity. They just have it. It's a fact. It's done. Let's be honest with them about the data. They can get a single dose of the vaccine. That's what some of us recommend for high-risk people, but they don't have to. We can't really use the term must, should, have to, need to. Those are relative terms and they oversimplify the benefits. My team at Johns Hopkins has been very frustrated with the NIH because they've spent less than 5% of their budget on basic COVID research last year. And the average time for them to give a grant after they've decided to issue a grant on COVID has been 5 months, just to give the researchers the money. During a health emergency, that's unacceptable. They should be doing the study right now of people who have had the infection and are 19, 20 months out. Those people are around. They should have their blood drawn, and we should evaluate how strong their antibody levels are. Are they as strong as they were in the weeks, months following the infection when we know they were protected? That study should be done. It's not being done. So my research team at Johns Hopkins, we've taken it on ourselves, and we are doing the largest study of natural immunity. The results will be forthcoming in the next few weeks or months. You can follow me on social media if you want to see the results. We'll see what the data show, but they are going to be very valuable data for a lot of people asking that question. Is natural immunity durable in the long run, up to 2 years? So we talked about kids, we talked about where we stand with COVID, and quickly on therapeutics. Do we have a minute for me to talk about therapeutics, Corey? There's a lot of stuff out there on therapeutics. So I'm going to tell it to you straight, and you'll see why both Republicans and Democrats hate my guts, because I will tell you my honest belief, and it doesn't fit in line with any political narrative. So hydroxychloroquine, I've reviewed the data on that. It's very convincing. The drug has absolutely no activity on the virus. You might as well just drink water. Actually, water might be more helpful than hydroxychloroquine. On ivermectin, the data are not compelling against ivermectin. I would call it non-conclusive. The studies that people point to show that it has a benefit do have significant limitations. The consensus in the field is that it probably also has no activity, but we can't say that with certainty like we have good studies now with hydroxy. That's the honest truth on ivermectin. But there are many other therapeutics out there that work that we're not hearing about, that many of which can be used today. Fluvoxamine is an antidepressant medication that blocks an inflammatory pathway that has a good randomized control trial showing a clear-cut benefit. It's called fluvoxamine. May be ideal for people with mild or maybe even moderate COVID. Also, steroid nebulizers approved in Europe for COVID, but not in the United States. We've basically been downplaying it. We're really so focused on vaccines, we've not been talking enough about therapeutics. Saline nasal sprays, the kind you buy over the counter, hypertonic saline nasal sprays that have been used for viral infections for decades by doctors successfully, also have been shown to be effective against COVID in a randomized control trial. And then finally, there's a drug that I cannot wait to see available out there. It's called molnupiravir, named after a tool of the Greek god Thor, which was the hammer of Thor. It's being put out there by Merck. You may have seen the phase 3 trial result was so impressive a few weeks ago. They stopped the study early because it was so dramatic. The survival benefit was dramatic. And hospitalizations were cut almost in half. And no one who received molnupiravir died. Very important finding. 8 deaths in the placebo arm, 0 in the molnupiravir arm. No COVID patient who's ever received molnupiravir has ever died. That is significant. It's profound. Unfortunately, this drug, although it was developed last year at Emory University, is sitting on the shelf. Millions and millions of these pills are sitting on the shelf, pre-purchased through Operation Warp Speed. But the FDA will take another 2 months after the 3 weeks they've already taken to ponder the most basic, simple data set we would analyze on our research team in about 4 hours. And that's with 2 different statistical teams working independently. How many statistical tests do you need to run on the number 0? I wish this drug were out sooner. I've written about this for the Wall Street Journal. It will be out at some point, maybe a little too late, but no one should be dying of COVID right now. Between all these therapies and monoclonal antibodies, which are the products of Regeneron and Lilly, nobody should be dying of COVID right now. You add to that the opportunity to vaccinate people who don't have immunity through natural or vaccinated immunity. Nobody should be dying of COVID right now. So that's the tragedy of it. So people have questions, we can chat about that. Maybe I've chatted a little too long already. So thank you, Corey. And I do want to say, by the way, you mentioned AHPT and Visa Health. I am very excited to be working with AHPT through Visa Health. And I know Corey will be discussing that. So thank you.
Yeah. Thanks, Marty. A couple questions before, Reagan, if you want to see if we can gather some questions from the audience. Knowing that we have employers on this call and thinking through all the questions that I get from employers, and probably you do too, could you just address at least 2 things? The accuracy of rapid testing and where we sit from current appropriate quarantine times.
Yeah, sure. It's nice to see Jay Kempton. I know he's going to be saying some words here, so good to see you, Jay. Yeah, with the quarantine thing, we've gotten totally messed up. I mean, right now, with the quarantine recommendations of, they came down from 14, and many of us saw the data that suggested they should be somewhere in the 5 to 8 day range, but the government didn't want to make such a big jump from 14 to 5. They thought it would just look like politically we're making such a big adjustment, even though it was based on some good science. So they landed on 10. Unfortunately, we're still living with some of that remnant policy, and it's ignorant to the level of risk an individual has. So college campuses, namely like Georgetown University, are putting kids in a hotel room where they're not allowed to leave for 10 days. They're all fully vaccinated. They're, 99% are low risk. What are we doing? We really lost our mind with quarantining. I think for employers, I think a reasonable time period may be 5 to 8 days. If somebody has tested positive and they don't have immunity. If they have immunity, it can be shortened. Some employers have moved to a simple policy of they don't want anybody in who has symptoms or has tested positive in the first 4 days of testing positive. I think that's reasonable, but I think we can't rely on the CDC to give us guidance that's tailored to every individual. On the testing, the rapid tests can be helpful because they're done quickly, but they have a lot of false negatives. That is, they're missing people with COVID. So in the early pre-symptomatic phase, when you first get exposed to COVID, the sensitivity can be as low as 50%. And that's what happened. That's what went wrong in some of these settings where you may have heard it's a testing fortress. And then there's an outbreak within the testing fortress. Where it went wrong is that they're using the rapid tests that miss up to 50% of cases in early stages or with mild symptoms. The PCR tests are so sensitive that they may even be too sensitive. When you get a positive PCR test, there's definitely virus in your nose. However, it's so sensitive, it can pick up one dead virus particle, so you may really pose no public health threat. And that's why many of us have said, hey, we need to maybe dial down the hyper testing, because if we test everybody, 5% of the population in perpetuity forever are going to be testing positive. It doesn't necessarily mean they're a public health threat when you have an immune population.
Thanks, Marty. Jay, do you have any questions, or Reagan, have we received any from the audience?
I think we do have one. Reagan, do you?
Yeah. We have a question of the spelling of the drug Biomeric that we're waiting on FDA.
Yeah, it's called Molnupiravir, Molnupiravir, and it is made by Ridgeback Biotherapeutics, marketed by Merck, and they submitted their emergency use authorization application 3 weeks ago. And I have a piece on it in the Wall Street Journal I think it was last week, on how the FDA needs to move quicker on it. You're not hearing enough about therapeutics, and I think people are concerned, public health officials are concerned, that if we talk about therapeutics, people might say, well, then I don't need to get vaccinated, I'll just take the therapeutics. Unfortunately, I do see that out there. I do see people say, well, I don't need to get vaccinated because I'll just get the therapeutics. Well, with the Regeneron antibody therapy, which people have a lot of faith in, we're talking about a 12 to 15% survival benefit. It's not going to rescue everybody from severe illness. Finally, I'll say that, I'm very pro-vaccine. I think everyone should be vaccinated who does not have natural immunity. But in a young person, the risk-benefit analysis is not a profound. It's not a profound benefit, and we have to respect opinions that may differ from our own. If somebody has a concern, we've not been good in medicine at simply saying we don't know. If somebody's saying, well, could the vaccine cause a flare of my primary biliary cirrhosis disease? We too quickly have dismissed the question and simply said, no, you're fine, it's safe, you should take it anyway. The reality is many times the answer is we don't know. Now, with the long-term safety of vaccines, people often are hesitant because they say, well, how do we know what it's going to do in a year or 2 or 3? With any vaccine in medicine, when you do see complications, you see them in the first few weeks after administration. You don't see them pop up a year later with any vaccine. You see them immediately. Now, there are complications from vaccines, let's not sugarcoat it, but you do see them immediately. So the safety profile that we're seeing now is likely the safety profile that people can bank on.
I got one other topic for you to address. You know, it's on the news every single day, and it's starting to impact all of our lives. But the mandates that employers are handing down from a immunization standpoint, from the first responders to, you know, the medical field in and of itself. Would you like to opine on your thoughts?
Yeah, I wish we had a more flexible vaccine requirement. We would have done a lot better as a country. You could argue maybe safer on the streets with more police officers and first responders with a more flexible vaccine requirement. We'd have more nurses on our labor and delivery units and surgical suites with a more flexible vaccine requirement. What I'm referring to is recognizing natural immunity and crediting that towards an immunity requirement. If we want to protect our patients, turns out the natural immunity is more protective. We didn't see that sort of flexibility. We saw a lot of rigidity. I talked to a student recently who has a real unique, rare medical condition where after the first dose of the vaccine, he had a significant reaction. And his doctors, and I've spoken with him and his doctors, we've all decided he should not be getting the second dose. By the way, he's super low risk. He's a college student. What are we worried about? So we decided one dose was enough for him. Well, a medical exemption letter was written, and the university wrote the nastiest reply saying that they're not going to recognize the exemption letter, that he will, if he does not get the second dose, he will forfeit his tuition, which will be non-refundable and not allowed on campus. That kind of rigidity is not good for public health. And we're seeing a lot of that. I think people have some good reasons to not get vaccinated when there's blood clots that run in their family and they're concerned, or there's other unique medical conditions. Not all the diseases read the textbooks, and everybody is different. And for people who have a strong feeling about it and talk to their doctor, we would do better with more exemptions.
Agreed.
Thank you. Reagan, do we have any other questions?
We've got one other question, and it was, how effective are the infusions?
Monoclonal antibody infusions, I take it, like Regeneron and Lilly's drugs. I'll assume that's the case.
Yeah.
So you're talking about, let me just point out, and for all I know, I don't know if pharma is on the call or not here, or
No.
just, okay.
Just buyers.
Just buyers and the cyber criminals who are hacking in, which I want to welcome to the conversation. So pharma has driven the narrative on monoclonal antibody infusions. They help, for sure. You're basically getting infused an intact immune system. You get it by an IV infusion. We haven't had enough centers set up. Operation Warp Speed downplayed a lot of therapeutics, including molnupiravir and the monoclonal antibody infusions of Pfizer, of Lilly, and Regeneron. So as a result, we've been in short supply, and people have said, hey, look, this is an important thing. Now, the reality is the survival benefit is 12 to 15%. That is roughly for every 8 people who get it, 1 person will live because of the therapy. So there is a benefit, but again, it's not a silver bullet. So it's something that you should seek out. It's not something that was even being offered to a lot of people. It's amazing. If you get COVID in America today, most of the pandemic, if you called your doctor, you basically were told, sit it out, sit at home. There's nothing to do. Turns out there's a lot you can do. And one of those things is seek out the infusion therapy. They are coming up with a subcutaneous version, which is a version you sort of stick in like a vaccine into your muscle. And that'll help a lot with the administration. We're going to get to a point where we need to learn to live with COVID. This is not going to go away. We've got to recognize that at some point we've got to move on with society. All infectious diseases are risks, and we can choose to each live on our own personal international space station, or we can learn to accept certain risks. And I think once you're immunized, once the therapeutics are out, including molnupiravir, we should feel good about being out there. And for many people, they're already at that point. People are going to have to assess their own individual risk. Unfortunately, policymakers often say things like, should we, open this or do this or require this, or the reality is people are going to have to assess their own individual risk, because if you're talking about a high school baseball game outside, you're really talking about the safest setting in the lowest risk population on planet Earth. If you're talking about, crammed bingo hall in the nursing home among unvaccinated seniors, then that's a different set of policies. So I think we're going to have to increasingly recognize that we have to assess our own individual risk. Same goes for kids and the vaccine. Kids with comorbidities, in my opinion, should definitely get vaccinated. Otherwise, it's a conversation with the pediatrician that may conclude with, hey, the benefits are there, the benefit is not compelling, but it's the numbers are there to support it. Maybe one dose, maybe 2 doses spread out by 3 months. Those are the conversations that our pediatricians are very good at having with parents.
Yeah, it's good information.
Yeah, I think to a certain extent we're learning to live with it. I watched a couple football games this weekend, and I literally was looking for masks in the crowd. I saw one with the 2 NFL football games. I saw one mask, and I didn't see an empty seat in either house. So we're learning to live with it. Marty, I thank you for your time today. It's greatly appreciated, and keep us up to date on what's happening out there.
All right, thanks, Corey. Good to see you. Good to see you, Jay.
Wonderful content, Marty. Thank you.
Thanks so much.
Jay, would you like to say a few words, or you want me to dive right into my less fun topics?
I think you ought to dive right in. We just appreciate the bankers' time and attendance this morning. I think having Dr. McCary on was a great bonus, and I know you enjoy a pretty close business relationship with Dr. McCary. I've known him from just attendance at the Free Market Medical Association conferences, but I hope the bankers recognize that he is a pretty high horsepower expert when it comes to COVID. So we're all very thankful that we were able to have him on the webinar. So with that, Corey, why don't you get us on down the agenda?
I will. Just one comment about that. To the extent that you have a question for Marty, feel free to reach out to me or him directly. He's very open. What I appreciate about him is his comments are it's the honest truth regardless. He's bipartisan, if you will. He just will tell you what he's seeing from research and from his experience, and I appreciate that, because I'm a skeptic on certain things, and I accidentally got my vaccines several weeks apart, because I wasn't going to get the second one, and lo and behold, it may have benefited me a little bit. So don't hesitate. We got an open door policy, so feel free to reach out if you have specific questions. I don't have the pleasure of talking about a current topic like COVID. I'm the legal, regulatory, and compliance arm of this show, so I'm going to apologize in advance. I'll try and make it quick. I wanted Marty to go as long as he could to get you guys as much information, and again, from a compliance standpoint, if you have any questions after the fact, you just feel free to reach out to me. I wanted to touch base on a few things. So as a reminder, the Advantage Health Plans Trust is a self-funded multiple employer welfare arrangement. We refer to it as a MEWA, and it's governed by ERISA, the Employee Retirement Income Security Act of '74, as well as certain state laws, and we operate in multiple states. So there's a lot of analysis that goes into laws when laws are changed and whether or not we have to comply and do we need to make amendments and things like that. So the folks on my end at Fiduciary Risk Management are in the process of reviewing several state laws right now, and whether or not they apply to the trust and whether or not amendments are going to be required. Just by way of example, the state of Texas has some mandates that they've handed down related to certain services for brain injuries, in vitro, cardiovascular disease. And so an analysis is taking place as to how those impact our plans in the trust and if we have to make amendments. Other items outside of Texas, autism, colorectal cancer, screening modifications under the ACA, as well as some plan language that may be required for the No Surprises Act, which is a new law that I'll talk a little bit about in a few minutes. Once the analysis is done, we will draft any required amendments that will be implemented into the plan. Which brings me to my next topic, which is electronic distribution. So last year, you would have received a memorandum from Kempton with regard to the electronic distribution requirements that are required of plans. ERISA requires that plan sponsors distribute certain plan materials according to the DOL regulations. They're kind of laid out on how we have to communicate to plan participants. The disclosures typically apply to summary plan descriptions, summary of material modifications, and there's a laundry list of things that have to be communicated on a regular basis and periodically to plan participants. Under ERISA, a plan sponsor is allowed to electronically communicate these documents to covered persons, and the rules automatically extend to any employee whom the plan sponsor knows with certainty can access these electronic documents at any location he or she works at and whose access to the employer's electronic information is part of their job. When it's not part of their job, there has to be a consent process where we go and obtain consent from individuals where it's not easily accessible through their current job, or maybe they're a COBRA participant, or maybe they're a dependent on a health plan under a qualified medical child support order, or somebody who's not necessarily in that household. Then the consent is required. And I haven't received any questions about electronic distribution. Kempton went through the process of obtaining email addresses from the participating employer so that we could communicate with them. As new employees come on, that email address is important so we can add it to the list of for distribution purposes. But just a good reminder that there are requirements when it comes to the distribution of those important documents under ERISA and the Department of Labor. Marty mentioned towards the end of his presentation, Visa Health. Beginning in April, the trustees approved a pilot project with Visa Health. The pilot was just shy of about 5 months in duration. Visa Health is a medical concierge program providing remote second opinions and high-touch clinical support to certain patients. The outcomes were quite remarkable. There were 12 individuals that were in the pilot. 10 of those individuals received remote second opinions. 2 individuals only required registered nurse clinical support. At the time the outcomes were reported, there were only 8 individuals that had completed their services with Visa Health. But just with those 8 individuals, the trust saved just over $450,000. There's surveys that are provided from the patients that participate, and the comments that were received kind of spoke volumes about the program. I just jotted down a couple of them. You're the best thing that's ever happened to me in the medical field, and I felt so supported from day one. This is the best program. I am glad my employer participates in. From a clinical category standpoint, the majority of the individuals impacted were dealing with endocrinology, rheumatology, and orthopedic issues. The remaining fell into kind of cancer, gastro, and undiagnosed categories. 100% of surgeries were avoided, and 100% of the patients changed their treatment plan. 83% of the patients reduced their healthcare utilization, and 29% of patients received an entirely different diagnosis. The numbers are quite staggering and scary from a patient standpoint. The trust has moved forward with full implementation of Visa Health. This is offered free to plan participants. There is a dedicated registered nurse for the trust plan participants. And as the program is being rolled out, you will receive more information. And it's important for you to kind of be the champion on your end when people are talking about being diagnosed with something or being confused, feeling like they're lost in the healthcare system, being told that they need surgery. Any of those type of, high opportunity areas should be recommended to Kempton and or Visa so that we can kind of manage those individuals. Marty mentioned the program, as Marty is the Chief Medical Advisor for Visa Health. And so that's exciting for the trust and exciting to see the impact that can be made, not only from the financial health of the plan, but also the health of the plan participants. There is currently a member in the program that is being referred to as the $1 million case. The individual was misdiagnosed as a type 1 diabetic, was given insulin prescription, and was told to come back in a year. That patient is not a type 1 diabetic. So the financial and health outcomes for that patient are yet to be determined, but it's going to be significant.
Yeah.
Another topic that I would like to talk about is a dependent audit. Fiduciary risk management has been tasked with performing an audit of all dependents enrolled in the trust. You should have received an email with attached correspondence explaining the process before the first letter goes out to your employees. So why do health plans perform dependent audits? ERISA requires that self-funded health plans administer benefits according to the written terms of the plan document. And it would be a violation of ERISA for an ineligible plan participant to receive benefits under the plan. Typically, more than half of all plan participants enrolled in a plan are dependents, and some dependents that are currently enrolled in group health plans may not meet the eligibility criteria. A dependent audit requires that employees provide proof of dependent eligibility for health plan purposes. A dependent audit is critical to the compliance, cost containment, and the management of the trust to ensure that the fiduciaries are adhering to their responsibilities and plan assets are only being expended for coverage of those individuals that truly are eligible. Most health plans of this size, of the size of the trust, typically do a dependent audit every 3 to 5 years. I'm uncertain, and Jay, maybe you would know the answer to this, if one has ever been done for the trust. But this is not.
No, the trust has not ever done a dependent audit. It's always been kind of on the honor system, but as things have gotten so much more complex and, I guess more flexible in the definition of a family unit in society, it felt like it was overdue. It was time.
Yeah. And so when we start going through this process, I don't want anybody to think this is unusual or, why are we doing this? Is something that really should be done periodically to make sure that we only have true dependents on the plan. And it's not always it's not always someone trying to sneak somebody onto the plan. It very well could be at times where we find folks on plans that they just truly didn't understand the eligibility requirements and what was required of a legal spouse or what kind of dependents could come onto the plan and what the requirements were. So it's just good to double check.
Yeah.
Sorry. So how does it work? All employees who are currently have enrolled dependents will receive a letter from Fiduciary Risk Management asking for substantiating documentation. And there's a list. The easy ones obviously are marriage licenses and birth certificates, but at times some people can't find those, and so there are other things that can be accepted. And that's all spelled out to the employee. We've made it as easy as possible for them to upload their documentation. If they can't upload it, they can fax it, they can mail it. We will accommodate everybody to the extent that they need it, just to make sure that we can get the information and verify the eligibility. The letter will provide a deadline in which to submit the substantiating documentation. A follow-up letter will be sent to those individuals we don't hear from. A third follow-up letter will be sent to the individuals we don't hear from. If we don't receive a response from individuals by the end of the process, dependents will likely be terminated from the plan. And as you can imagine, it's fact specific as we kind of head down this path. In the discussions with the trustees in deciding to move forward with a dependent audit, the trustees have agreed to allow participating employers to opt out of an audit if the employer is willing to sign an attestation. This is, from my standpoint, this is highly discouraged, and I doubt that we'll have a lot of participating employers that will take that route. And the reason being is you are basically saying that you, with 100% certainty, can attest to the fact that all of your employees, that the spouse that they have enrolled is a legal spouse, and the dependents are dependents pursuant to the terms of the plan. And if something were to happen, and let's say a large claim was incurred and it hit the stop loss threshold, and now the stop loss carrier is asking for substantiation in the form of a marriage license, a birth certificate, and ultimately it was determined that they weren't dependents, that participating employer would be held responsible. And I don't think for many or any of you on this call, that's a position that you would want to put yourself in, but the trustees wanted to allow that as an opportunity for those that want to opt out. And so that was included in the communication that was sent to the participating employers.
Yeah, it's a big step to to attest to that. But of course, there are banks that are very closely held. They have very little turnover. They know we actually had a trustee that actually had mentioned that they had attended every one of the marriages and were very, very close with their employees and felt very, very comfortable with the attestation. And in those limited scenarios, I think it maybe makes some sense. For other banks, other employers, I think it's good to have it documented, just to be safe.
Yeah. I have done several dependent audits for plans across the country. I've never done a dependent audit where somebody wasn't found to be on the plan impermissibly and that they had to be removed. And given the nature of healthcare right now and the dollars that are being billed to patients and plans, I literally have a claim on my desk for a 2-month stay for an infant that ultimately died in the hospital, and the claim came in at $14,700,000. So there are dollars and cents that I don't think any of us want to be gambling with, and it's just easier to require the substantiation and use it as sleep insurance, if you will. The next couple topics I'm going to talk about are a little bit more complex, and it's going to sound very, very regulatory, and I apologize. So bear with me a little bit.
You're not going to shock any bankers, I can assure you.
Yeah, they're used to
regulations.
Yeah. Yeah. So earlier this month, the IRS and the Department of Treasury released guidance. It was in the form of Notice 2021-58, clarifying certain deadlines relating to COBRA continuation coverage in connection with the ongoing pandemic. The IRS, Treasury, and the DOL had previously released several pieces of guidance delaying and extending many common deadlines for employee benefit plans. So once COVID hit and we started wrapping our arms around, what this looked like, the regulators came down with kind of open-ended deadlines, right? So dates and timelines that we used to have to live and die by kind of had this laissez-faire approach by the regulators because they didn't know what was going to happen. They didn't want anybody to be negatively impacted because of a pandemic, and so deadlines were kind of out the window for a while. Ordinarily, a plan participant has up to 60 days after they receive a COBRA notice to elect COBRA coverage, and another 45 days after the election is made to make their first COBRA premium payment. In addition, group health plans generally are required to give participants at least a 30-day grace period for payment of each subsequently monthly premium payment. So there's a lot of opportunities right here, right? So under the prior COVID release guidance, these deadlines were extended by up to 1 year during the pandemic. Notice 2021-58 clarifies that the 1 year extension applies individually to each covered deadline for each participant, but that each 1 year extension applicable to a given participant runs concurrently. The result is that the total amount of disregarded time with respect to any given COBRA participant, election, and payment deadlines under a given year cannot exceed 1 year. So for example, suppose that the regular 60-day deadline to elect COBRA expired in 2020 during the outbreak period, and the outbreak period continues indefinitely. It's starting to look that way. If the participant elects COBRA 75 days after receiving the COBRA notice, then for purposes of determining the deadline to make an initial payment, the participant is treated as having made an election on day 60. Thus, the total amount of time that the participant has to make the initial payment is 1 year plus 105 days after the notice was provided. That 105 is the 60 plus the 45. However, if the participant elected COBRA within the 60-day window, then the 45-day clock would start immediately when they elected COBRA. Thus, the deadline for making the COBRA premium payment for them is 1 year and 45 days. Similarly, subsequent premium payments are due within 1 year after the date they would have been due had all prior elections and payments been timely made under the ordinary law and the terms of the plan. Essentially, folks that are tardy are going to benefit from Notice 2021-58, and that's somewhat unfortunate, but that's the hand that we've been dealt as of right now. So some plans that were applying a more liberal interpretation of prior guidance may have already extended coverage to participants whose COBRA premium payments would have otherwise been late under the new rule. In response, the DOL has offered a limited transition rule, which under an initial COBRA premium payment will not be treated as if it were late if, number one, it was made no later than November 1st of 2021, and number two, it is made within 1 year and 45 days of the election date. The IRS also clarified that the 1 year extension of deadlines does not affect certain deadlines related to notices and elections with respect to the COBRA premium assistance coverage under ARPA, the American Rescue Plan Act, which provided the free and extended COBRA coverage, if you will recall those regulations. Under ARPA, Section 9501 required that certain employers offer free COBRA coverage to certain individuals between April 1st of 2021 and September 30th. So that has come to an end. Through that process, the ARPA provided the tax credits to offset the cost of COBRA coverage. The right to free COBRA coverage extended to only certain individuals. They were referred to as assistance eligible individuals. These individuals were COBRA qualified beneficiaries who were enrolled in COBRA coverage under a group health plan on or after April 1st of 2021 if coverage under the plan is lost or was previously lost due to, and there were specific categories. They were reduction in hours such as furlough and layoff, or termination of employment other than a voluntary termination. A couple other key points in that ARPA section was that the free COBRA did not extend past what would have been the normal expiration date for the underlying COBRA coverage period, so typically that 18-month window. And the offer of free COBRA coverage also would cease if the individual became eligible for other group health plan coverage. including a spouse's plan or eligible for Medicare, regardless of whether or not they enrolled. If they just became eligible, then they were not eligible for the free COBRA. And the onus was on the COBRA qualifying individual to let the group health plan know of that eligibility, because otherwise we would not know. And the regulations created a tax penalty of like $250 if they did not properly notify the group health plan of that eligibility. So that's the update on COBRA. We have a little bit more guidance and parameters surrounding our deadlines, but it's still greater than I would like it to be, because what the regulators, I mean, they know it's out there, but they don't care, essentially, is that we have stop loss policies that we have to deal with regard to plan years. And so it's very important that we're tracking these deadlines, tracking these individuals, and kind of watching for potential large claims to the extent that we can, so that we don't miss an opportunity for our reimbursement under our stop loss policy.
Correct.
Okay, let's see how we're doing on time. Okay, I only have one topic left, so I'll get us through this and then see if we have any questions. So this is a big one. The Consolidated Appropriation Act, otherwise known as the CAA of 2021, brought about a lot of different regulations, many of which have delayed enforcement dates. This is where we're seeing a lot of the transparency regulations, and we had a lot of other regulatory issues when the pandemic was kind of at the forefront, and they've been dragging on. But a lot of the provisions in the CAA, their enforcement deadlines keep getting pushed down the line. Unfortunately, there's one called the No Surprises Act, and that's not the case. This is a bipartisan bill. It was intended to curb surprise out-of-network billing. Specifically, the bill was to ensure that plan participants can't be required to pay anything other than the in-network cost-sharing amounts for certain services, such as out-of-network emergency care, out-of-network air ambulance, certain ancillary services, and out-of-network care provided at an in-network facility. Are you going to say something, Jay?
Yeah, it's anesthesia that most often, and radiology. Yeah.
Yeah. So
inpatient.
Prior to the No Surprises Act at the federal level, there were many states that had implemented no surprise billing laws for several years, actually. An example, and Jay just alluded to it, an example of a no surprise bill, kind of the perfect example, is when you go to a facility to have a surgery done, and when you get your EOB, that's when we discover, or when we get the claim and then the subsequent EOB that's generated, that's when we discover that the anesthesiologist that did the procedure, that did the anesthesia during the procedure, is an out-of-network anesthesiologist. And all of a sudden there's this big bill to a patient, and how were they to know that the anesthesiologist wasn't in network when the facility was in network? I'm going to hit on the high points of the actual No Surprises Act regulations, and then try and assure you that there's nothing to worry about, because between myself and Kempton, we're going to figure out how this is all going to play out. There's a little piece of me that's hoping this may disappear. It's probably not going to happen, but we have been expecting further rulemaking in the 2021 plan year. It's coming to a close. We're in the fourth quarter. This bill is effective January of 2022, and I don't have any additional rulemaking that I've seen yet. So with any luck,
the comment period doesn't start until December 6th.
Yeah, I'm hopeful that
Think about that for a minute.
Yeah, there's going to be a lot of surprises under the No Surprise Act. But I'm just gonna hit on the high points, so that when you start seeing some changes at the plan level, you understand why you're seeing them. So section 102 and 105 of the No Surprises Act deals with medical billing and air ambulance. So It requires health plans to cover emergency services without prior authorization at the in-network benefit level, regardless of whether emergency services were entered at in-network or out-of-network. So a big difference will be how emergency services and air ambulance services are treated under the plan as a result of this bill. Section 103 of this act pertains to the independent dispute resolution process, which if I think about this too hard, it's laughable. But this requires health plans to implement an independent dispute resolution process, which applies to emergency services rendered out of network or non-emergency services rendered at an out-of-network provider at an in-network facility. So that anesthesiology example. And after a 30-day negotiation period, if the plan and the provider can't come to an agreement, then it goes to an independent dispute resolution process, basically like arbitration. So these claims come in, there will be a process to determine what's paid. The payment is made. The provider doesn't like it. Now we have to go to essentially arbitration or dispute resolution on all of these claims. But I don't really know what that's going to look like, but that's what we're faced with. Section 106 is an air ambulance reporting provision. It requires health plans to submit 2 years of claims data relating to air ambulances to the secretary. They're just gathering some information, which they should have done before they implemented the No Surprise Act. Section 107 is the ID cards. There's certain requirements that a couple components have to be on the ID card to satisfy these regulations. Section 110 pertains to the external review of surprise medical bills. This allows the existing external review process that's currently in the plan to apply to determining whether the surprise billing protections are applicable when there is an adverse determination by the health plan. Section 111 pertains to the advanced explanation of benefits. So this is a huge one from an administration standpoint. This requires group health plans offering coverage to automatically provide an advanced EOB upon receiving notification from a provider or facility that a participant or enrollee is scheduled to receive an item or service from a specific provider. I've moved mountains before trying to get a quote out of a provider's office. So the fact that they think we can provide an advanced EOB with no information is going to be a challenge. Section 112 is the provision relating to good faith estimates. It requires healthcare providers and facilities to verify 3 days in advance of service and not later than 1 day after scheduling the service what type of coverage the patient is enrolled in and provide notification of a good faith estimate and whether or not the patient has coverage. There's a continuity of care provision that I won't get into. And then section 114 requires a cost comparison tool. It requires health plans to offer a price comparison tool for consumers and make information available by phone. The tool must allow an individual enrolled under such plan with respect to a certain plan year, geographic region, and participating provider to compare the amounts and the cost sharing. I mean, basically, they want the patient to be able to become a healthcare consumer, and we need to provide them with the tools to do so. And that's just something that we're all trying to figure out how that's going to actually work in practice. And then the last section is section 116, provider directory information. Again, requires health plans to have up-to-date directories of their in-network providers and the ability to access information upon demand. I can't decide if I feel that this is less or more attainable than I did 20 years ago, Jay, when we had the HIPAA privacy regulations and they were being imposed upon us. At that time, the thought of requiring HIPAA authorizations to speak to nearly anyone seemed like an impossible burden. And yet here we are, pretty much immune to it at this point, right? So now we
Numb.
have this.
Numb is better description, I think.
Yeah, numb. That is better. And now we have this, and I guess my closing comments is no surprises here. But the implementation and effectiveness may be the surprise, as this does become effective as of January until further guidance. And the good news for AHPT is that you are partnered with Kempton, and they will be one of the leading TPAs across the country, making all efforts to be in compliance with these regulations, whether they are sensical or not.
Yes, as we always do. Yeah, we will be generating kind of a timeline, kind of a roadmap, if you will, for No Surprises Act. We should have that out within probably a couple of weeks. Like I've talked to a lot of bankers and consultants, and everybody wants, well, just tell me what I got to do. We'll tell you what we have to do right now, but this is going to change quite a bit, as opposed to, we've been through this together, for many years and decades for some of the banks, as we know that sometimes these things change prior to implementation. I think that No Surprises is going to change prior to implementation, but I think it's going to probably see more change post implementation. As we all know that the government, especially as it relates to healthcare, it's very much kind of a fire ready aim type of approach. And the fact that a lot of these things go into effect in January, but the comment period doesn't start until first week of December, tells us that the effective date is very much ahead of the regulators really understanding how this thing even is going to work. How are they going to enforce it? That's why the enforcement has been put off for, in some situations, over a year past the implementation date. So it's like everything. Just kind of hang on for the ride. We will give you a roadmap of kind of where we think we're going here in the next couple of weeks, but stand by, because this is going to be a moving target.
That is for sure.
Okay, Corey, well, that was some great information. I'm looking at our questions. I don't know if we have any additional questions. Of course, you know that Corey is available for any member bank. You can always call Kempton, and we can certainly relay or even get on a conference call with Corey and the fiduciary risk management team to resolve questions. If it's something that is particular to your bank, maybe facts and circumstances related, or anything that's maybe private of nature, please give us a ring after the webinar. Reagan, are you seeing what I'm seeing, that I think the original 3 questions are the only 3 that we've got, unless you see something different?
Nope, it looks like all of the questions that have been answered.
Okay, very good. And one of our earlier questions was, is this webinar going to be made available after it's over? And I answered that, yeah, of course. This is being recorded, and not only the video, the audio as well will be shared out on the Advanced Health Plans Trust YouTube channel, and we'll be sending a link around as soon as that is available out there on YouTube. We'll send a link out in one of our communication blasts via email. But of course, you can always see any webinars related, user group meetings, compliance webinars, etc., out on the Advanced Health Plans Trust YouTube channel. So, Corey, anything else?
I don't think so. Thank you for having me. I know it was a lot of information, and as you mentioned, I'm available if anybody needs me.
You bet. All right. Well, everybody, enjoy the rest of your Monday, and thank you all very much for your investment of your precious time this morning. Thanks, everybody.
Thank you.